Hello, class, and welcome back to your coagulation lectures. Today, we will be discussing thrombotic disorders and their lab assessments. We will also talk about antithrombotics and the thrombotic disorders and lab assessments can be found in the Rodak's Hematology, Clinical Principles and Applications, Chapter 39. And again, my name is Carolina Vilches, and I will be presenting this chapter for you today. So the first thing that we need to do is define thrombosis. Thrombosis is another name for clotting. It's the inappropriate formation of a platelet or fibrin clot that obstructs a blood vessel. It is a multifaceted disorder that results from circulatory stasis and abnormalities in the circulation system, or rather the coagulation system, control mechanisms, platelet function, blood vessel walls, or leukocyte activation molecules. Thrombotic obstructions cause ischemia, which is the loss of blood supply, and necrosis, which means tissue death. Thrombophilia was actually once called hypercoagulability, and thrombophilia is a condition that predisposes a person to thrombosis, secondary to a congenital or acquired disorders. Here are some known causes of thrombophilia. Any physical, chemical, or biologic events, such as acute chronic inflammation that release prothrombotic mediators or suppress blood vessel production of normal antithrombotic substances. Some other causes include uncontrolled platelet activation, uncontrolled blood coagulation system activation, blood coagulation control protein deficiencies, etc. Thrombophilia can be inherited or it can be acquired. Thrombophilia is a cumulative effect. There has to be a combination of risk factors which increase the risk of thrombosis. In terms of its prevalence, it is a common cause of death in the USA, and it is accounted for 1 of every 3 deaths. A venous thromboembolic event, a VTE, occurs in 1 in 1,000 individuals, and it's more prevalent among African Americans and women of childbearing age. There are 2 types of thrombophilia. There is arterial thrombophilia or venous thrombophilia. When we are talking about the arterial thrombophilia, we call it the white thrombi. In the white thrombi, you will find platelets and fibrin and few white blood cells and red blood cells. This implicates myocardial infarction, peripheral vascular disease, stroke, a transient ischemic attack. These are caused by thrombi that block coronary arteries or the carotid and arteries of the vertebrobasilar system. Arterial thrombophilia is more platelet related. On the other hand, a venous thrombophilia involves the red thrombi. The red thrombi is composed of red cells and fibrin. A deep vein thrombosis is the most prevalent type of VTE, which occurs in the legs, in the upper extremities, and the patient will feel localized pain, the sensation of heat, some redness, and swelling. Another type of a VTE is a pulmonary embolus or pulmonary embolism. These are thrombi or thrombophilia that occurs in the veins. A DVT or a PE is more coagulation factor related. So what happens when someone experiences a pulmonary embolus or pulmonary embolism? So fragments of thrombi are called emboli that can separate from the proximal end of a venous thrombus. They move swiftly through the right chambers of the heart and lodge in the arterial pulmonary vasculature, causing ischemia and necrosis of the lung tissue. Nearly 95% of PEEs, of pulmonary embolus, arise from thrombi in the deep leg and calf veins. There is something to remember. Hemostasis is a balance between prothrombotic and antithrombotic mechanisms. If there is an increase in prothrombotic factors, such as clotting factors, thrombosis will occur. If there is a decrease in prothrombotic factors, then bleeding will occur. If there is an increase in antithrombotic factors, such as clotting inhibitors, bleeding will occur. If there is a decrease in antithrombotic factors, then thrombosis will occur. Here are some factors that seem to contribute to venous and arterial thrombosis to varying degrees. A risk factor could be something like age. There can be thrombosis after the age of 50, and risk doubles each decade after 50. Immobilization. So someone who is sedentary, or they have an occupation in which they drive long distances for a long time, air travel, and restriction to a wheelchair or a bed. Obesity is also a risk factor in a type of immobilization situation. In this particular case, the way that all these factors contribute to thrombosis is that there is slowed blood flow, which raises the risk of thrombosis. Diet is another risk factor. Things like fatty foods, inadequate folate or vitamin B6 and vitamin B12. The rationale for this is that there's a condition called homocystinemia, which is associated with 2 to 7 times increased risk for arterial or venous thrombosis. Lipid metabolism imbalance. So conditions like hyperlipidemia, hypercholesterolemia, dyslipidemia, elevated lipoproteins, elevated triglycerides, etc. These are factors that also increase the risk of thrombosis. There is a moderate arterial thrombosis association with the LDL-C, the LDL cholesterol elevation, and hypercholesterolemia. Oral contraceptive is another risk factor, so the use of formulated progesterone could add to thrombophilia. Pregnancy increases the risk of thrombophilia. Hormone replacement therapy, femoral or tibial fracture, a hip, knee, or gynecologic surgery, prostate surgery, smoking. It also depends on the degree. Inflammation, if it is chronic, predisposes the person to arterial thrombosis, and the placement of a central venous catheter, which can cause endothelial injury and activation. In addition to lifestyle events, several conditions and diseases threaten patients with thrombosis. So diseases like the antiphospholipid syndrome, myeloproliferative neoplasms, hepatic disease, cancers such as adenocarcinoma, leukemia, paroxysmal nocturnal hemoglobinuria, and chronic inflammation. So let me just go back to antiphospholipid syndrome right now. So some examples are the chronic antiphospholipid antibody, often secondary to autoimmune disorders. When there is a chronic lupus anticoagulant that's circulating, there is an increased risk of stroke, myocardial infarction, recurrent spontaneous abortion, and also venous thrombosis. In the laboratory, we can diagnose and we can find antiphospholipid antibodies by doing an APTT mixing study. We can also run a lupus anticoagulant profile. We can run an anticardiolipin antibody and an anti-beta-2 glycoprotein 1 immunoassay. Together, transient and chronic antiphospholipid antibodies such as glucose anticoagulants, anticardiolipid autoantibodies, and anti-beta 2 glycoprotein antibodies may be detected in about 1 to 2% of the population. Again, chronic antiphospholipid antibodies confer a risk of venous or arterial thrombosis, and the condition is called antiphospholipid syndrome. Let's talk about the antiphospholipid antibodies. Antiphospholipid antibodies are a family of immune globulins that bind protein phospholipid complexes. They include the lupus anticoagulants and the anticardiolipin antibodies, as well as the anti-beta 2 glycoproteins. Antiphospholipid syndrome is characterized by chronic autoimmune antiphospholipid antibodies. So it is defined by the patient having transient ischemic attacks or strokes or coronary and peripheral artery diseases, VTEs, and or recurrent pregnancy complications. Clinicians suspect antiphospholipid syndrome in a situation in which there is unexplained venous or arterial thrombosis or thrombocytopenia and or recurrent fetal loss. We have specialized coagulation labs which have the antiphospholipid antibody detection profiles, and those can include clot-based assays for the lupus anticoagulant, or they can include immunoassays for anticardiolipin antibody and also for the anti-beta 2 glycoprotein antibodies. Occasionally, a lupus anticoagulant is suspected because of an unexplained prolonged APTT that does not correct in mixing studies. So, with the antiphospholipid antibodies, there is a detection profile in specialized laboratories. Again, we can do clot-based assays for lupus anticoagulants. We can do immunoassays for anticardiolipid. We can do immunoassays for anti-beta 2 glycoproteins as well. And again, mixing studies whenever a lupus anticoagulant is suspected to cause an unexplained prolonged APTT. There is also a diagnostic criteria. And so we diagnose the antiphospholipid antibodies when there is 1, the presence of venous or arterial thrombosis or pregnancy morbidity, and 2, the presence of 1 or more positive tests at least on 2 occasions, and they are 12 or more weeks apart. So these are the tests that should be positive. The anticardiolipin, which is an immunoassay. We can use an IgG or an IgM by ELISA immunoassay, or the anti-beta 2 glycoprotein 1, which is another immunoassay by ELISA, or the positive lupus anticoagulant done by a clot-based assay. So for the antiphospholipid antibodies to be diagnosed, there has to be the presence of 1, venous and arterial thrombosis or pregnancy morbidity, and 2, the presence of 1 or more of these tests to be positive on at least 2 occasions and 12 or more weeks apart. So we have 2 immunoassays, the anticardiolipin or the beta 2 glycoprotein 1, and lastly, the clot-based assay for a lupus anticoagulant. So antiphospholipid antibodies can be either transient, which disappear after about 12 weeks, or they can be chronic. So most arise as either IgMs or IgG isotypes. Sometimes they are called nonspecific inhibitors because they bind to a variety of protein phospholipid complexes. About 1 to 2% of individuals of both sexes and all races are affected. And about 5 to 15% of individuals with recurrent venous or arterial thrombotic events have antiphospholipid antibodies. Most antiphospholipid antibodies, however, arise in response to bacterial, viral, fungal, or a parasitic infection or treatment with various drugs. Again, some can be transient. When they are transient, they disappear within 12 weeks. It is more of an alloimmune response with no main clinical consequences. If the patient is positive for an antiphospholipid antibody, he or she must be followed up to determine the persistence of this antibody. On the other hand, you have some antiphospholipid antibodies that occur in association to disease. One of them could be a collagen vascular disease. Others, about 50% of patients, will have the presence of antiphospholipid antibodies when they have lupus erythematosus, which is an autoimmune disease. Antiphospholipid antibodies that are more of an autoimmune response can be found with patients that have rheumatoid arthritis or scleroderma, and also in primary antiphospholipid syndrome. So when a patient has primary antiphospholipid syndrome, antiphospholipid antibodies can arise spontaneously. These types of antibodies, antiphospholipid antibodies that are associated with autoimmune diseases can persist for longer than 12 weeks, and about 30% of autoimmune antiphospholipid antibodies are associated with arterial and venous thrombosis. So again, these tend to be more chronic, and typically an antiphospholipid antibody that tends to be chronic could be a lupus anticoagulant. A chronic lupus anticoagulant can persist for about 12 weeks. Again, it is an autoimmune response. It responds, and it is clinically significant. It increases the risk for arterial and venous thrombosis, which can relate to stroke, seizures, transient ischemic attacks, coronary artery disease like a myocardial infarction, and deep vein thrombosis or pulmonary emboli. Also, lupus anticoagulants or chronic lupus anticoagulants have been implicated with recurrent pregnancy complications and fetal loss, infertility, and thrombocytopenia. So in the laboratory, as I mentioned, some antiphospholipid antibodies can be detected via immunoassays by ELISA, and others, like a lupus anticoagulant, can be identified by using a clot-based assays. So what we do is we typically have a lupus anticoagulant test profile that involved assays that are clot-based. So basically, we are looking for a clot, and we are timing for the time it takes to clot. So in these types of instances, what we do is we use a reagent that has reduced phospholipid concentration, which would deem this reagent sensitive to lupus anticoagulants. There are two commonly tests used for the detection of lupus anticoagulants. We use two tests. We use the dilute Russell Viper venom time, the DRVVT, and a silica-based APTT or PT. Both of these tests would be run with a low phospholipid concentration, which is designed to be sensitive to a lupus anticoagulant. A confirmed positive result in one of these tests is conclusive despite a negative result in the other test profile. The 2009 International Society on Thrombosis and Hemostasis released the guidelines for lupus anticoagulant detection, which require the following sequence. First, you must have a prolonged phospholipid-dependent clot formation using an initial assay such as a low phospholipid APTT test or a low phospholipid, the DRVVT test. This type of test is often called the PTT or DRVVT screen. Second, the failure to correct the prolonged clot time when you do a mixing study with normal patient or platelet plasma. And repeating the test. Third, a shortening and/or correction of the prolonged initial assay results by addition of a reagent formulated with excess phospholipid, and this is often called the PTT or the DRVVT confirm. And lastly, you must exclude any other type of coagulopathies. So there is a sequence to the diagnosis of lupus anticoagulant by using a screen phospholipid-dependent test and a confirm test, which has higher excess of phospholipid reagent, and a mixing study. And so what happens is that there is sort of like no standard way of ordering the test or running the test. So the order of the test may vary depending on the situation, depending on the lab. First, you run the screening test, or that's ordered, and then you do the confirmation and then a mixing study, or you can do the screening test first, then a mixing study, and then a confirmation test. Either one there is no wrong procedure as long as we can confirm the presence of the lupus anticoagulant. The plasma that we use must be double centrifuged to get PPP, platelet poor plasma, to prevent the interference from platelet phospholipids, and it is affected by anticoagulant therapy. So if the patient is on some sort of anticoagulation therapy, we cannot perform the test while the patient is taking it. We would perform the test about 10 to 14 days after the patient stops the therapy. Okay, so let's just recap mixing studies, and we did talk about this before. Mixing studies are a great way of determining if a patient is suffering from a major factor deficiency or a circulating inhibitor. A common inhibitor is a lupus anticoagulant, and that's why this is a type of test that can be included when we are doing clot-based assays. So the main point of a mixing study is to determine if pooled normal plasma will correct a prolonged APTT. You can also run a mixing study to determine if a mixing study will correct a prolonged PT. You take one part patient plasma and mix that with 1 part PNP, pooled normal plasma. Basically, it could be a 1-to-1 dilution. You can use 500 microliters, 30 microliters, 100, whatever the case may be, as long as they are equal parts. So your patient plasma, 500 microliters, add that to pooled normal plasma, 500 microliters. Then do an APTT on the 1-to-1 mixture. When you do the APTT, you figure out whether or not your APTT was corrected or not corrected. And here are the definitions, right? So if there is a correction, meaning the time to clot gets shortened, right? Then that means that the PNP supplied the missing coagulation factors and was able to correct the abnormal APTT. No correction, on the other hand, well, this could mean that there is a circulating inhibitor. There are 2 types of circulating inhibitors. The one that we're concerned with right now is the lupus anticoagulant. But there is also the factor-specific antibodies, and those inhibit coagulation factors directly in both the patient and in the PNP. You may also be looking at an inhibitor like a lupus anticoagulant that is inhibiting the phospholipid protein complexes of the APTT. If there is a correction immediately, another mixture is prepared and incubated for about 1 to 2 hours at 37 degrees Celsius. And then you run that mixture again for the APTT. After incubation, if you see a correction, then we have a different type of scenario. If you don't see a correction, then we have a different type of scenario as well. And here are the I'm going to go through those cases. I have 3 different scenarios for mixing study in the subsequent slides. So a correction, what does that mean? In terms of a mixing study, it's defined as a one-to-one mixture having an APTT value within 10% of the undiluted PNP result. So basically, you have your patient prolonged APTT, but you also run an APTT on the pooled normal plasma. And that's what you basically base your subsequent results on. You just could go back to those results and compare. And then that's how you'll see whether you have a correction or no correction. So a correction is defined as having a one-to-one mixture having an APTT value within 10% of the undiluted PNP. Another way to do that is within 5 seconds of the PNP, or within the reference interval of the APTT, or by the calculated index, which is the index of circulating anticoagulant, Rosner of 1987. So there are 4 different ways in which we can compare our new APTTs to the older APTTs to see if we have a correction, but you can stick with the within 10% of the undiluted PNP result, and that should be okay. But if you are doing it in the hospital, then you must follow the protocol that the hospital gives you. And no correction is defined as a one-to-one mixture not meeting the established criteria for a correction. So anything else other than what is listed for a correction. So again, mixing studies can help in the identification of either factor deficiencies or inhibitors. Our inhibitors can be immediate acting or time-dependent inhibitors. So I have 3 different cases here that I'll go through with you. Case number 1, we have a patient that has a prolonged APTT, and we can't figure out why. Their plasma is mixed with pooled normal plasma at a 1-to-1 ratio, so 1 part patient plasma and 1 part PNP. This mixture is tested immediately with the APTT. If the APTT is corrected, which means if the new tested APTT gets corrected, it means that its value is within 10% of the undiluted PNP result. Then this means that there was an immediate correction. If you get a correction, you must take that mixture, or you must make a new mixture of a 1-to-1. So take your patient and then take 1 part patient and 1 part PNP and incubate that for about 1 or 2 hours. The reason why we have an incubation period is because we might have time-dependent inhibitors that will come up to the light once the sample gets incubated. Then you test that sample again. If the APTT is corrected again, then this means that the patient has a probable factor deficiency because the PNP provided the mixing factors. In this particular case, and because we are using the APTT as an example, the laboratory professional should proceed with single factor assays looking for factor deficiencies in the main factors involved that are not tested with a PET. So that would be factor 8, factor 9, or factor 11. So they would run a factor assay, which is a different type of assay, and you can do that in the instrument as well, in the Stagger instrument. The other scenario is case number 2. Then you have a patient here with an increased APTT. Their plasma is mixed with pooled normal plasma at a 1-to-1 ratio. This mix is then tested immediately for with the APTT. If the APTT is not corrected, which means that the value is now within 10% of the undiluted PNP result, then this means that there was no immediate correction. When there is no immediate correction, the sample is no longer tested because the patient probably has an immediate acting inhibitor in their plasma. So it's not a factor deficiency. It is an immediate acting inhibitor that is affecting and that is prolonging the APTT. In the third scenario, we have a patient that has an increased APTT. Their plasma is mixed with pooled normal plasma at a 1-to-1 ratio. This mixture is tested immediately with the APTT. If the APTT gets corrected, meaning the value is within 10% of the undiluted PNP, This means that there was an immediate correction. When we have an immediate correction, we have to go ahead and incubate a new aliquot. So we make a new specimen, a 1-to-1 ratio, 1 part patient, 1 part PNP. Then we incubate that for about 1 to 2 hours at 37C, and then we retest that. If the APTT, once we are testing it, of that new incubated aliquot is not corrected after incubation, this signifies the patient has a time-dependent inhibitor or a type of antibody that is dependent on time and temperature in order to act. So here is the algorithm for mixing studies. So we have a patient that has initially an APTT that gets prolonged for unexplained reasons. And so before we do anything, we want to make sure that we can rule out any other things other than a factor deficiency or any circulating inhibitor. And so when you have an APTT that's constantly prolonged, we can't figure out why. Let's start with running a thrombing time. So a thrombing time will be really good because we can determine if heparin is present in the sample. So I'm going to take my little pencil here, and I'm going to draw in the slide to see if you can see. So we have an original APTT that is prolonged, and it's right over here. So to determine if there is heparin that is actually affecting our sample, let's do a thrombin time. If the thrombin time test, all right, which is right over here, if the thrombin time test is prolonged, then that could mean that there is heparin in the sample. Okay, so let's stop right here. If the thrombin time test, after you have done a prolonged APTT, you run a thrombin time, if that comes out normal, then that means that we can rule out heparin, and then we can move on with our test and doing our mixing study. However, if your thrombin time is long or prolonged, then there's a high chance that there's heparin in the sample. So what we can do is use hepsine. Hepsine is a heparin neutralizer, right? So it's nice because we have some options. We can treat that sample with hepsine, and then we can repeat the APTT. If the new APTT test is normal, then what that means is that we must run an assay for heparin, okay? If the APTT was still prolonged after we treated with hepsine, then we go ahead and we run our mixing study. So there are some steps that we must go through before we actually go through the mixing study option. So it's quick. I mean, we can do a thrombin time and then possibly treat with a heparin neutralizer and then take it from there. Again, but if the thrombin time is normal, then you can go ahead and do your mixing study. And also, if you treat with hepsine, you repeat the APTT, and the APTT is still elevated, then you run a mixing study. Okay, so here is how it begins, right? It begins with our increased APTT from our patient. I'm trying to draw here with my little finger. I'm getting better and better each day, so that's good. AP. Scratch that. APTT. There you go. And then another T here. There you go. Okay, so we begin with a patient that has a prolonged APTT. And so we mix the test plasma, our patient, with normal plasma or normal pooled plasma on a 1-to-1 ratio. And then we run an APTT on that mixture. Okay, if the APTT is uncorrected immediately, then we go ahead and run for lupus anticoagulant because we can suspect that there's a lupus anticoagulant that's pretty much happening immediately, because it is very typical for lupus anticoagulants to inhibit right away because they are phospholipid complexes. They are anti-phospholipid antibodies that like to attach to those phospholipid protein complexes that are being created during the testing. And so they like to attach to that. So it's going to interfere no matter what. So it's really affecting your test right away, okay? The other scenario is we mix our patient plasma with our pool normal plasma and we run for the APTT. And then this new APTT here actually gets corrected, okay? It gets corrected. Let's say, initially my APTT was, like 65 or something like that, right? And so now I did my mixture, I run an APTT, and now all of a sudden I'm getting 30, okay? So in this case right here, that means that it was corrected because it is very likely that the normal pooled plasma gave me a very lower, a low number APTT originally. Okay, so then when you get a correction, we have to still take another aliquot and incubate that at 37 degrees Celsius for about 1 or 2 hours, and then repeat that APTT on that aliquot, all right? Because there can be a time-dependent inhibitor, okay? So if we run it again and we get another correction, okay? So in this case, we have correction. That means that the PNP that we added here is probably giving us our factors that we need. So this indicates there is a factor deficiency. So if there's a factor deficiency and we're running an APTT, it is very likely that the factors that are deficient are factor 8, okay? All right, this is taking me a long time. Factor 8, factor 9, or factor 11, okay? So there you go, factor 11. All right. And the other case scenario is that, yes, we had a correction, we incubated, and then we ran again, and all of a sudden now there is no correction. Okay. So what this means is that this was probably a time-dependent inhibitor, and it is very likely that time-dependent inhibitor will be something like an anti-factor 8 inhibitor that can just be circulating, and it needed a little bit of an incubation period in order to act. Okay, so let's go back to the lupus anticoagulants that we talked about before. So in the case in which we are right over here, we did a mixing study and we ran it and it didn't get corrected. We don't do anything more. We sort of suspect that there's a lupus anticoagulant. So the next step is to go ahead and run that lupus anticoagulant screen and confirmation tests. So here is the lupus anticoagulant test algorithm, which can vary from lab to lab. So again, if the APTT is prolonged, perform a mixing study. Most commonly, the lupus anticoagulants do not correct the APTT immediately. Sometimes there is an immediate reaction, however, it is not corrected after incubation at 37C. Let's just say a lupus anticoagulant will not correct your sample right away. Then we have to run either the screening test or the confirmation test, okay? So if the doctor suspects that there is a lupus anticoagulant, they will perform the lupus anticoagulant specific testing. And most lupus anticoagulant protocols will begin with a DRVVT, but they can also run the APTT, a phospholipid-based assay. All right, so let's begin with the screening test. So we use the DRVVT assay using low phospholipid reagent. So if this DRVVT screen using a low phospholipid reagent if the result exceeds the upper limit of the DRVVT reference interval, then you could presume that there is a lupus anticoagulant present. And then after that, the practitioner will perform a confirmatory lupus anticoagulant test. That test would be the DRVVT assay using high phospholipid reagent. Okay, so what happens here is that you compare the results in seconds to the DRVVT results of the screening test. Okay, the reagent, right, the phospholipid reagent here neutralizes lupus anticoagulants, and it's supposed to shorten the DRVVT. Okay, that's why we use high phospholipid reagent. It will neutralize the lupus anticoagulant and shorten the DRVVT. If the screen result is prolonged over the DRVVT confirmation result by a predetermined ratio, which is typically 1.2, then a lupus anticoagulant can be confirmed. If the DRVVT ratio is less than 1.2, then you can go ahead and perform a silica-based low phospholipid PPT or APTT using the same steps as the initial DRVVT. And I have a flow chart here that will be a little bit more helpful. And here is the flow chart that helps us determine the presence of lupus anticoagulant. All right, so with the screening test, okay, you will use a DRVVT assay using low phospholipid reagent. If the DRVVT screen using low phospholipid reagent results exceed the upper limit of the DRVVT reference interval, which is greater than 1.2, then a lupus anticoagulant is presumed. Then the practitioner would pretty much run a confirmatory DRVVT test, okay? So the confirmatory DRVVT test right over here is an assay using high phospholipid reagents, okay? So the results here will get compared to the results in seconds of the DRVVT screen, okay? If the results here are prolonged over the, if the ratio is prolonged over the DRVVT confirmatory result by a predetermined ratio, which is typically 1.2, then a lupus anticoagulant is confirmed right over here. So if you get a ratio of greater than 1.2, then you can confirm that lupus anticoagulant. If your result is 1.2 or less, then you can perform a silica-based, right over here, silica-based APTT test using low phospholipid reagent. And so you would pretty much do the same thing that you did in this case scenario, okay? So if your results are more than 1.2, you run a confirmed test, an APTT test using high phospholipid reagent, and if your results after that come out to more than 1.2, then you can confirm that it is a lupus anticoagulant. However, if after you ran the silica-based low phospholipid reagent APTT and your result is 1.2 or less, then it is negative for a lupus anticoagulant. If you ran it and it was more than 1.2, but then you ran the high phospholipid reagent APTT, then and your result is 1.2 or less, then it is also negative for lupus anticoagulant. So this is the algorithm that is very commonly used in the laboratory to detect these lupus anticoagulants. But a mixing study can be done first, and then once the presence of this lupus anticoagulant is very much suspected, then you can run the screening test and the confirmatory test, okay? But we begin with a low phospholipid reagent because that's sensitive to lupus anticoagulants, okay? And we have a predetermined ratio of 1.2. All right. And then your confirmation test is always something that you will be using with a high phospholipid reagent. Okay. So when you use the high phospholipid reagents, that high phospholipid tends to neutralize and shorten the time. And it'll give you a different ratio. All right, so those are the two ways. Now, it is very common for laboratories to do a mixing study and then run the DRVVTs. And if the DRVVTs can't confirm it, then they go back to the silica-based APTT with low and high phospholipid reagents. Okay, so with that said, now I want to talk about some congenital thrombosis risk factors. And some of these are diseases, okay? So there are some congenital thrombophilic disorders that predispose a patient to thrombosis. So one of them is antithrombin deficiency, protein C deficiency, free protein S deficiency, activated protein C resistance, and prothrombin G202108, homocystinemia, and hyperfibrinogenemia. So these are disorders that predispose the patient to thrombosis, and we'll talk about some of them in the next slide. So the first one is antithrombin deficiency. Antithrombin deficiency occurs in 1 in 2,000 to 1 in 5,000 individuals. And the patient has a relative risk of thrombosis. They can be either heterozygous for the condition or homozygous for the condition. Heterozygous, they have a risk. However, the higher risk develops when the patient is homozygous for this condition. Again, this is congenital antithrombin deficiency, so the patient can inherit this as a heterozygous or homozygous condition. And 100% of these patients develop thrombosis. So to detect this, we use clot-based or chromogenic assays, and also we can use immunoassays. Protein C deficiency. Protein C is a very important regulator in the inactivation of factor V and factor VIII. And so protein C deficiency renders the patient with a relative risk of thrombosis when there is deficiency of protein C. Heterozygous have a risk, but there is more of a risk with homozygous inheritance of protein C deficiency. 100% of those patients develop thrombosis. And we can use clot-based assays, chromogenic, and immunoassays to determine these deficiencies. Free protein S deficiency, the prevalence is unknown. And patients have a relative risk of thrombosis as well. And again, the homozygous inheritance, it predisposes the patient to 100% development of thrombosis. Another condition is the prothrombin G202108 mutation. This type of thrombophilia condition occurs in about 2 to 3% of Caucasian individuals. There is a guanine to adenine point mutation at the position 20210 in the 3' untranslated region of the prothrombin gene. This increases the prothrombin activity to about 130%. Remember, what is the normal function of prothrombin? There is a relative risk of thrombosis, with heterozygous being 1.6 to 11.5 fold risk of thrombosis. The only way to determine this kind of genetic mutation is by doing molecular assays, looking for this particular G20218 mutation. So let me talk about activated protein C resistance, which is also known as factor V Leiden. So you can hear APC or factor V Leiden in the same manner, or we can talk about them in the same way. So factor V Leiden is actually the name of a city in the Netherlands, and that is where this mutation was first found. The activated protein C and protein S complex normally hydrolyzes activated factor V and activated factor VII, right? So basically what it does is that it prevents these major factors, factor V and factor VII, from being activated all the time, right? And so when there is a mutation in the factor V gene, okay, and there is a known mutation in the factor V gene where arginine is replaced by glutamine at the amino acid position of 506. This mutation in factor V actually occurs at the cleavage site for activated protein C. Okay, so where protein C comes in to inactivate factor V, there is an actual mutation there in factor V, and the mutation again is that arginine is a point mutation. Arginine is replaced by glutamine at this particular position. And so because of this mutation at the site of factor V, activated protein C is not able to hydrolyze activated factor V. And so again, because of where this was found, this condition is called factor V Leiden or activated protein C resistance. So factor V Leiden is resistant to inhibition by activated protein C. It happens in about 3 to 8% of Caucasians, but it's very rare in African Americans or Asians. 60% of pregnant women with venous thrombosis will have factor V Leiden, and 20 to 5% of individuals with a first instance of venous thrombosis will have a condition like this, like factor V Leiden. And so, in terms of thrombotic risk, homozygotes have a 3-fold higher risk of thrombosis, but homozygotes have an 18-fold higher risk of thrombosis. So we can detect this activated protein C resistance or factor V Leiden by doing some clot-based assays, but mostly nowadays this is detected by doing molecular test. And again, factor V is named for the city in the Netherlands. Factor V Leiden was a city in the Netherlands in which this was first identified. All right, so here is a way in which we can detect activated protein C resistance using clot-based assays. So you take the patient plasma and you mix it with a 1-to-4 factor V depleted plasma and the APTT reagent. You add that to 2 aliquots of the mixture and you incubate that for 3 minutes. A solution of calcium chloride is added into one mixture and the clot formation is timed. A solution of calcium chloride with activated protein C is added to the second mixture and the clotting time is recorded. Clot formation of the second aliquot is at least 1.8 times the time to clot formation of the first. The second test should be longer in seconds. Activated protein C will prolong the APTT in normal patients due to the inhibition of factor V and factor VIII. The normal ratio between APTT results is 1.8 or greater. In activated protein C resistance, the ratio is less than 1.8. We use factor V depleted plasma because factor V depleted plasma compensates for potential factor deficiencies and also for oral anticoagulant therapy by providing normal coagulation factors to the mix. So again, the normal range here is 1.8 or higher. In activated protein C resistance or in factor V Leiden, the patient will have a ratio of less than 1.8. Okay, since we're talking about thrombotic disorders, we have to touch on disseminated intravascular coagulation. That's also known as DIC. Another name for it is consumption coagulopathy. And here, there is a generalized and uncontrolled hemostasis activation that is secondary to a systemic disorder. It's microangiopathic, which means it is a condition in which fibrin microthrombi form and occlude small vessels where they consume platelets, coagulation factors, control proteins, and fibrinolytic enzymes. It produces the types of cells of blood cells called schistocytes, and these schistocytes are visible on the peripheral blood film. Schistocytes, and examples of those are broken fragmented red blood cells. As the blood cells are passing through those small vessels, if they are occluded with microthrombi, the red blood cells will break up, and in turn, what you will have are the cells called schistocytes. FDPs, fibrin degradation products, including D-dimers, are elevated in DIC, and they may interfere with normal fibrin formation as they coat platelets and fibrin. Events here in DIC set loose toxins and inflammatory processes with secretion of inflammatory cytokines. This can be acute and uncompensated, or DIC can also be chronic. Although DIC is known as a thrombotic process, the thrombi that form are small and they are often ineffective. So the real issue here with DIC is systemic hemorrhage, systemic bleeding, and it is often the first or the most apparent symptom. Here are the causes of disseminated intravascular coagulation, and they can be listed based on the disorder mechanism. It can be due to tissue factor release into circulation, exposure of subendothelial tissue factor during vasodilation, endotoxins that activate cytokines, circulating immune complexes, infusion of activated clotting factors, secretion of proteolytic enzymes, and platelet activation. Chronic DIC is known to be associated with tissue necrosis, liver disease, renal disease, chronic inflammation, and vascular prostheses, etc. The more acutely ill the patient is, the more dangerous DIC becomes. So here's the pathophysiology of DIC. The release of tissue factor triggers the extrinsic pathway and activates platelets. Exposure to interleukins, hemolysis, and cell necrosis triggers activation of factor 12 in the intrinsic pathway. Endothelial cell exposure to interleukins triggers the release of TPA activating plasminogen, tissue plasminogen activator. That's what TPA stands for. Circulating thrombin becomes the primary culprit because it further activates platelets and coagulation factors leading to fibrin formation. Thrombin further activates fibrinolysis, resulting in the formation of free plasmin. A percentage of fibrin monomers fail to polymerize and circulate in plasma as soluble fibrin monomers. Monomers tend to coat platelets and coagulation proteins, creating an anticoagulant effect. Thrombin, fibrin monomers, fibrin polymer, and cross-linked fibrin all activate plasminogen to form active plasmin. Plasmin circulates in the plasma and digests all forms of fibrinogen and fibrin. FDPs and D-dimers are detectable in the plasma. Platelets get consumed in fibrin polymer, leading to moderate thrombocytopenia, or a decrease in the platelet count, and protein C, protein S, and antithrombin are consumed in the clots. So it is very important that we can diagnose and treat DIC immediately, okay? So here are some anticipated results of disseminated intravascular coagulation in terms of the primary lab profile that we will run to confirm the presence of DIC. Other than that, we also have some specialized laboratory assays that can assist in the diagnosis of DIC. So primarily, you want to take a look at some of the routine tests. So if we suspect DIC is happening, it's important to look at the platelet count. The platelets start to get consumed in the, activated and consumed in the clots. So there is a drop in the platelet count, which will give you a moderate thrombocytopenia. So you'll have a platelet count that's less than 150,000 per microliters of blood. Then you can examine the peripheral blood film, in which you would see anemia accompanied by schistocytes. Schistocytes are present in about 50% of DIC cases. Also, leukocytosis, or a high white blood cell count, is common. Then you can take a look at your routine coag-based tests. So the PT, the prothrombin time, is usually elevated. The APTT is usually elevated as well. Take a look at the thrombin time along with the reptilase time, which a thrombin time will be prolonged, okay? Another key factor here that you'll see is a D-dimer. D-dimers are typically around up to 240 nanograms per milliliters, or 0 to 500, depending on the assay that you're running, okay? But these D-dimers would be increased. And take a look at fibrinogen. The reference range for fibrinogen is about 220 to 498 milligrams per deciliter, but the fibrinogen gets consumed, inactivated, so you will have a reference range that's lower than 220. More specialized assays that you can review are the protein C, protein S, and antithrombin assays. Those will be decreased in value at less than 50%. You can run serum FTPs, which will be increased along with the D-dimers. You can run a plasminogen, a TPA, or a plasminogen activator 1, which will be decreased because they are constantly being activated. You will find a positive soluble fibrin monomer because monomers are unable to polymerize, and that's a hemagglutination assay. This is a specialized assay. We don't do it all the time, but it's very helpful in this process. And you can also run factor assays. For example, a prothrombin factor assay, an assay for factor 5, for factor 8, and factor 10. And you would find that these factors are getting consumed in clots, so the activity of the factor would be less than 30%. We also talked briefly about heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is an immune response to unfractionated heparin and sometimes low molecular weight heparin, which is reflected in reduced platelet counts. It may progress to venous and arterial thrombosis. The incidence is 0.5 to 5%, and the HIT incidence relates to the duration and the dosage of heparin therapy. Some complications of HIT are DVTs, pulmonary embolisms, myocardial infarctions, strokes, limb ischemia, vein graft occlusions, and injection site skin lesions. The mortality among patients with thrombosis rises to 30%, and up to 20% of those patients who survive require some type of amputation. 30% of patients on unfractionated heparin develop mild thrombocytopenia, and there is a high index suspicion in patients that are exposed to unfractionated heparin and sometimes low molecular weight heparin. So the pathophysiology in this case concerns platelet activation. Besides platelet activation, inflammation is a part of the process here, the pathophysiology here with heparin-induced thrombocytopenia, and also thrombosis. So there is the creation of HIT antibodies against platelet factor 4 that have been complex with heparin. These heparin platelet factor 4 complexes are formed and it triggers an immune response producing an IgG isotope or anti-heparin platelet factor 4 antibodies. The platelets, this autoimmune response activates platelets and releases additional platelet factor 4, initiating platelet activation that generates procoagulant platelet microparticles, and sustained platelet activation contributes to platelet clearance, and platelet microparticles generate thrombin, resulting in thrombocytopenia and HIT-associated thrombosis. So the issue here with HIT is that there is thrombosis present because of this platelet factor 4 release and the immune response to the heparin platelet factor 4 complexes. So the immune system is activating the body. It's in an inflammatory state, and sustained platelet activation will contribute to platelet clearance, and platelet microparticles will generate thrombin, which then result in thrombocytopenia. So then there is a decrease in the platelet count and also associated thrombosis. So early diagnosis here for HIT demands a comprehensive interpretation of the lab information. The initial disease surveillance basically begins with checking consecutive platelet counts at least once every 48 hours during therapy and also after therapy. Keep in mind that HIT-related thrombocytopenia okay, is in which you would see a 30 to 50% drop in the platelet count from the pre-heparin levels, okay? So although patients with HIT can experience bleeding, the major risk here is thrombosis with thrombocytopenia, okay? There is a condition called de novo HIT, and de novo HIT, the platelet counts start to fall after 5 to 10 days after heparin begins, okay? So basically, you would get an increase. There is a way of scoring. This is called the 4T scoring system. It is checking for the probability of heparin-induced thrombocytopenia. And so for this, we need whether or not there's thrombocytopenia. We need to know the timing of the platelet decrease, count the thrombosis, the presentation of thrombosis, okay? And so you would get a patient would get a score of 2 if there is more than 50% decrease in the platelet count. If the onset of the decrease of the platelet count was between 5 to 10 days, or the onset of decrease on day 1 was present. If there is proven new thrombosis or skin necrosis, the patient would get a score of 1 if there's a 30 to 50% decrease in the platelet count, and more than 50% if it is directly resulting from surgery, or if there is an apparent decrease on days 5 to 10, but unclear due to missing platelet counts. So there is a whole scoring system that we can run for HIT. Basically, again, this is called the 4T scoring system, and it is very helpful in determining, it's a quick way of determining if the patient is experiencing HIT, which should be treated immediately. It could be dangerous because of the thrombotic events. So here are some indications for thrombophilia testing. And so we don't always run thrombophilic lab profiles, but we do if there are specific risk factors and if the patient is suffering from thrombotic events. So a patient who is under 40 to 50 years old having a DVT or a PE, thrombosis for unknown causes or recurring thrombosis at any age, thrombosis at unusual sites like hepatic veins, a family history of thrombosis, thrombosis with oral contraceptives or hormone replacement therapy or pregnancy, and any unexplained abnormal lab tests such as a prolonged APTT because of suspected lupus anticoagulants. And here you have a table. This is straight from the book, and it explains the assays that we could run for a thrombophilia laboratory test profile. So if we suspect activated protein C resistance, or factor V Leiden mutation, or the prothrombin G2021-A mutation, you can run a lupus anticoagulant profile, an anticardiolipin antibody, an anti-beta 2 glycoprotein antibody, antithrombin, protein C, protein S, fibrinogen, and homocysteine. So all of these tests are largely a part of the thrombophilia lab profile test. You may run some of these in the normal coag lab where you also do routine tests, but most of these will be a part of the send out test that will be done at a larger reference lab, where they have the potential to do more specialized testing.